Now, this is a rather busy looking slide, but this is just about everything that you need to know about ADH. And hence, I put all of this in one slide. Okay. Right. So we start with the anatomy first. Okay. Let me just readjust this. Right. This. This now is we have come to a schematic diagram. You can see the hypothalamus. You can see the tract. Then you can see the posterior pituitary, AVPC. It says AVP here, arginine vasopressin. This is basically ADH, made and packaged in neurons of the supraventricular and paraventricular, supraoptic and paraventricular nuclei. These vesicles then are transported and then are stored here, where they can be picked, released in the blood. This is something that we've just done. Okay. Now, coming to what shall we do first? Let's tick this off. Plasma osmolarity. We know that this is the normal range, 280 to 300, and see how sensitive vasopressin ADH release is. As you increase plasma osmolarity, ADH secretion goes up. So that's that. We've done that. Coming to this now. This is a nice, extensive, not extensive, but nice schematic flowchart. And look at the key first. The yellow sort of this shape is the stimulus. This rectangle, its color code may not be appreciated over probably over YouTube, but let me tell you that this stuff, right? This here, these three boxes, they are the sensors. Okay, then these boxes are the input signal. This is the integration center. This is the output, and this is the target tissue response, and then systemic response. It will all make sense when we do do this, solve this. So we said that ADH basically is released in relation with osmolarity. This is a nice line, one line to remember. High osmolarity or low blood pressure causes ADH secretion. It's a nice line. High osmolarity or low blood volume or both. Okay. Now, before we do this, let's do the osmolarity thing because it's most sensitive to osmolarity. Okay, anything greater than 280 milliosmol per liter, ADH should release normally. Okay, where is where is the sensor of this? It's hypothalamic osmoreceptors, as we just discussed, which is the input signal interneurons of the hypothalamus. All of this is happening in the hypothalamus, the neurons in the hypothalamus. We've talked about the two sets of neurons. What is released in relation to this stimulus? ADH is released. Its secretion is enhanced, increased. Okay. What does it do? What is the target output signal is collecting duct epithelium. What happens over there when ADH goes there? It inserts water channels or they're called aquaporins. Okay. Uh, Aquaporins or water channels are inserted. We'll talk about that in a bit. And when they're inserted, you have now the power to increase your water reabsorption, to conserve it in a situation of dehydration. Remember, the osmolarity was increased. So you have a situation where you have less water to solute ratio. Okay. So you need to conserve water to bring this osmolarity back to normal. Okay. Now, this would not have been possible if ADH wouldn't have been there to use its power or magic so that you can squeeze out the extra water from urine, which you wouldn't have done if the osmolarity was okay. Okay. So, in other words, when osmolarity increases, you take out from the urine more water than you would usually do. How is that possible? Well, there are two reasons. I'll give you one right now. ADH related aquaporin insertion in the collecting duct enables you to pick up more water than your usual scheme of things. Okay. The other, I will let you know as we flow along. Okay. Right. So we've solved this flow chart on osmolarity. Now let's quickly see what's happening here. Decreased blood pressure. uh, or any due to any volume loss or whatever, you see that what who brings the signal, who gets disturbed by this. The receptor is carotid and aortic baroreceptors. Remember, we mentioned baroreceptors in the initial diagram as well. The sensory neuron of the hypothalamus picks this up. Hypothalamus then starts making ADH. Remember, this is new information for you. What you read is the baroreceptors take information to the VMC in the brainstem, and you have all sorts of sympathetic or anti-sympathetic responses, which brings the blood pressure down or up, whatever is required. Now you are studying that that's not the only thing decreased blood pressure do. So this is important and crucial information for you, which you need to add to your blood pressure scenario. Okay. So when you decrease blood pressure, not just is the VMC become the boss. You also have that signal sent to hypothalamus, which then starts to, if there is a decreased blood pressure scenario, then the hypothalamus will start to make vasopressin, and then vasopressin will do its whole thing, similarly to what it did with decrease in osmolarity, increase in osmolarity. In this decrease scenario, ADH will be released. It will conserve water, and that water will go to ECF volume, make up for it, increase the blood pressure. Simple. Okay. Now, uh, decrease atrial stretch due to, so there are atria, this is the heart. Atria have stretch receptors inbuilt in their walls. If there is decreased volume of blood, these stretch receptors pick up that signal and then send it off to hypothalamus. Hypothalamus makes ADH. The same thing happens. Water is conserved, ECF volume is accommodated, enhanced, and hence those that stretch or lack of stretch signal by the atrial receptor is snubbed, or it's worked against. So these are the main things. The main being osmolarity and blood pressure responses on the release of vasopressin or ADH. Right. So we've been talking a lot about kidney, and this is obviously a kidney class. So we will now see, and I thought I will discuss it right here, so that when in Guyton does it a bit differently, but I think you should know this as part of your info diagram on ADH. So you know all you need to know about ADH. So whenever any book mentions ADH does this, does that, you know what ADH, the holistic picture of ADH is. That's why I put everything here. So next time I will just mention that ADH increases. I will expect you to I will expect you to respond or understand when we say that ADH increases. This happens in the kidney. Okay. So today and mainly tomorrow, we'll be talking a lot about ADH increases in scenarios where ADH is increased. Please remember that when you think about the kidney and ADH, this is the diagram which becomes operational. Okay. Now check this out. ADH came from the blood, obviously. Okay. These small boxes is ADH. This is where we start. So the ADH came in, it got transported into the interstitium, where it found the collecting duct cell with its receptor. It connects with the receptor. Please do read up on which are the receptor types and this, that, the other. That is a tutorial material, and you need to read up on this yourself as well. So vasopressin binds to its membrane receptor. There is a intracellular change which is mediated by cyclic AMP, and and that basically activates the receptor and the second messenger system, which you will read detail about in endocrinology. But let me just say that second messenger systems are intracellular messenger systems, which are linked with their typical receptors. When you activate the receptor, you basically not just activate one thing in the cell by by allowing the key of this receptor to come and connect with it, which in this case is vasopressin. You are activating a whole cascade of intracellular reactions called the second messenger system. Okay. So in this case, that second messenger system is being played out by the cyclic AMP, whose level it increases when you activate the ADH receptor with ADH. Now They're the storage vesicles which are which have aquaporin stored in them. They are activated because of this signal. They are already, remember, they are already pre-made as well. Not just these, this also activates the formation of aquaporins. Aquaporins are proteins, right? So who will make them? Who makes proteins in the cell? The transcription process. So specific genes, aquaporin genes are activated, which are transcribed, then translated, and their formation also increases. But that takes time. So that's why we have pre-made stuff already available for immediate release. And then that genetic machinery also gets started to make more and new aquaporins so that if you need it, in the current scenario, it becomes available in a few hours, but you will need it anyway. So the things that have been used up are replenished by the newly formed aquaporin vesicles. Right. So these aquaporin vesicles, when they are activated by the secondary messenger system, they go and they basically fuse with the with the apical side, the lumen side of the collecting duct. When they fuse with the membrane, what they contain, the aquaporin itself, it gets plugged into the membrane, the apical membrane, like this. So this is the vesicle. It got activated. It contains aquaporin. It became when it became activated, it fused. When it fused, it basically forced its content and pegged it inside in the membrane. So now you have a channel of water which you induced, which you have created just now, which wasn't there before. So this is an additional water channel now in this membrane through which extra water can be transported and reabsorbed. Okay, so this is that overview of what ADH does and how does it increase water reabsorption. This is how it increases water reabsorption. Again, a word to note, important point is, since it's all of this business is hormone related, hence it's reversible. Okay, water reabsorption via, say, uh, paracellular pathways to the tight junctions is constant. You can't do much about that. It's a constant feature. Uh, it's like you have a window in your wall. That's a hole, right? That's a hole in the wall. It's constant. If you drill a hole in the wall and then use plaster of Paris to plug it, then dislodge the plug, then plug it, then dislodge the plug. Let's say that is a reversible hole in the wall. But the window, the whole window, is irreversible. Let's assume that it's irreversible. So there are pathways for water transport which are fixed. You can't do anything about that. However, this ADH mediated aquaporin system is reversible. So you've understood what happens when ADH comes in. Now, if you think about if ADH now decreases in the blood. Now that you have reabsorbed water, obviously it's a negative feedback mechanism. So when you have water reabsorbed in the blood eventually, and that increase osmolarity scenario is now addressed, osmolarity goes back to normal. The vasopressin will obviously drop in the blood. Yes. This whole reaction will drop. Yes. Aquaporins will stop being inserted into the membrane, their levels will drop, and hence this newly created temporary extra water reabsorption scheme that you concocted, this also vanishes. Okay, so this is a reversible water reabsorption business, which comes only into play when you need it by meddling with the osmolarity, increasing vasopressin, and this, that, the other. Okay, remember this. The rest of the water reabsorption is constant. You need to have an obligatory urine volume for which you need to have a constant level of water in the urine. The fluctuation in that water is being discussed here. Okay, right. And then you can imagine, like, look, if we have solved this scenario for increased osmolarity, you can very easily solve it for decreased osmolarity. And I will leave it up to your imagination that if I were to say osmolarity lesser than 280, then you should now be able to solve this using this diagram. Okay. So the only thing left is this nice table that details increase ADH. When does it happen? In this scenario. Decrease ADH. When does it happen? It happens in this scenario. You just need to remember this. Remember, nausea and hypoxia are interesting entries for increase ADH. We have done these top three, which are the mainstay of the most uh, prominent of ADH handlers. However, nausea comes in important in the top five, and so does hypoxia. And then the reason I selected that, it also mentions some drugs that affect the ADH. This will come in later on when you go into your clinical training, inshallah.